Welcome to another interview of Sabra. We are delighted to have with us Mr. Saif Mohammad. Saif was the first state project manager for palliative care in Kerala. He's also special for me because he was the first person I interviewed for when I started my research in palliative care. So that's always a special person for me, but even otherwise, over the years, to have kept in touch and claimed the status of a friend. Uh, was the state project manager for palliative care in Kerala under the National Health Mission. He leads efforts for initiating primary palliative care programs and empowering local self-governments and facilitating specialized palliative care programs in secondary and tertiary hospitals. He has supported the works in formulating the palliative care policy for the government of Kerala and has served as the state coordinator for the palliative care program under the additional skill acquisition of the government of Kerala. I personally also know that he has worked with palliative care when we try to translate it to Nadia district in West Bengal, and Saif used to come over for the training. So in the initial months to train volunteers in Nadia in West Bengal, it was a very memorable time in 2014-15. Saif now is serving as a consultant and faculty member of the World Health Organization Collaborating Center at the Institute of Palliative Medicine. And he works in, and the IPM, for those of us who are not familiar with the work of IPM, is basically it's a nodal organization which is working on training, advocacy, research, but also the care delivery for the Pain and Palliative Care Society in Kozhikode. It is in this capacity as a consultant faculty member at IPM that he facilitates capacity development workshops for governments and organizations in different low and middle income countries. He's a faculty member of the Global Fellowship Program organized by IPM WHOCC and the St. Christopher's Hospice London. He's also actively involved in implementing the international program for developing the bereavement companions in collaboration with the Support for Death Literacy Institute Australia and the Institute of Palliative Medicine. So welcome to this summer conversation, Saif. And I really look forward to hearing from you on this journey of yours in palliative care, but also now with this Bereavement Companions program. And joining me is Sabar team member, Shaima, who's also, I'm pretty sure, excited about this conversation. So thank you, Saif.
Yes, of course. Thank you so much, Saif, for joining us. Could you share a bit about your background and how is your personal journey, including any particular experience, influenced your focus on palliative care in Kerala, more recently the bereavement support?
Yeah, sure. And before I do that, and a big thank you to Devi, who has been a long time friend, and also Shaima, for giving this opportunity. And it's always a pleasure to talk about palliative care, which is a big passion of mine. So thank you for the platform and the opportunity. So coming to your question, actually there is a small story behind how I got, introduced or exposed to palliative care. My studies, I did my graduation in pharmacy. So I was in Bangalore. I was doing my studies there. So once in a while, I used to visit my home back in Kerala. So one day when I got back home, my mom told me that my neighbor, who is like an elder brother to me because it's a very close-knit community in a small village. So my mother told me that he's suffering from some serious illness, and he was taken to the medical college, which is far away from our village. And then he was undergoing treatment, and he came back. And the situation is so worse that he might die anytime. So I was really shocked to learn about it because he's in its mid-40s and he used to be very healthy. He was a daily wager. And he was supporting the family, a very nice man who used to visit our house and with a very lovely personality. So I was really sad and shocked to hear this news. So in the same afternoon, I went to his house, and what I saw there was totally, very what you say, that he was really suffering. Like he was on his bed. He was not the person I used to know before, because he has lost a lot of weight, and he was, having a nasal tube attached to his nose, and he was, most of the time he was on his bed. And when I went to the bedroom, usually he's a person who speaks a lot, but this time when I went there, he just smiled at me. He was trying to smile. I don't know whether it was even a smile. And then he just, looked to the other side of the wall, and he was just lying there. So I didn't know what to say, what to, do in that situation. And I was speaking to his wife, his mother, and then I got back home. And then that almost stayed in my mind, like, this is really difficult. What he's going through is really a lot of suffering. But I couldn't do anything. I was just helpless. And the next morning, when I got back, when I got up from my bed and I went to the veranda of the bedroom, what I see is that there is an ambulance in front of his house. So the last day when I went there, he was really suffering, and I could know that things have really gone bad. And seeing an ambulance in front of his house, that means I had the doubt that he passed away. So I told my mom that there is this vehicle, and then I ran to his house. But what I saw there was really surprising. It was not a regular ambulance. It was written palliative care, home care on that. But I couldn't even read it, because that's the first time in my life I'm coming across the word palliative. So I went, and there was this driver who was just leaning to the vehicle. And when I entered his house, there were few people sitting around his bed. And he was not the same person whom I, saw yesterday, because this time he was smiling. He was almost leaning to his bed, and he was trying to speak. Because the people who visited was very familiar to me, and a couple of them were familiar to me also, because they were all familiar to him, and two people in that team were familiar to me. So one was an auto rickshaw driver in the village, and the other was an retired school teacher, and then a nurse. So the nurse was attending to the tube and other things. And these guys were there sitting and speaking with the patient as well as the family members. So I was really, surprised. I was like, what's happening here? This is kind of, people coming in a vehicle, and then this person has totally changed. He's speaking to them. And then that was a good thing to see what was happening there. And I got out of the house, and I had a casual talk with the driver who was there outside the house. So he told me that this is palliative care. This is something that we go into the homes of people who are suffering from incurable illness, those who are bedridden, and we take care of them. So there will be a nurse, and also there will be people who are interested. They join us, and we teach them. So they also accompany us. Later I learned that it's nothing but the psychosocial support that they give. This is all, most of them were lay persons who were part of the program. So that really was interesting. And then he told me that if you are interested, if you want to see whether this is your kind of thing, you can come to a meeting. And then there was a meeting which was the monthly affair of that palliative care unit. So I went there, and most of the people were all lay persons, like housewives, auto rickshaw drivers, teachers, retired hands, students from the colleges. So they're all sitting, and they're talking about the patients whom they are visiting. They're talking about their issues and what they were able to do and things. So that was really, amazing. So I thought that I should join this. And then the next time when I came back, I took the training, and then I started off as a volunteer. So that's how I started with palliative care. And when by then I completed my studies, and what I was doing was that I was completely spending my days with the local palliative care unit in my place, which my dad was not very happy about, because we have a family business, a medical store and things like that. So I'm the only son, so he wanted me to take the business up and running, but I was, bunking the shop and going there. Most of the days I was spending time with palliative care. But anyway, that was really, I mean, those couple of years, what I have done was just going out with the home care team, meeting patients, and also not only along with the team, but I mean, in my free time, I'll go to the patients whom we are supporting, just sit with them, listen to their stories, and support them in whatever way possible. So that's how I found my passion in palliative care. I'm sorry it was a bit long, but that's the story.
And
Yeah.
I haven't heard this story, so this is great. I'm really happy to hear this also. But the place that you're talking about, is this Moscow?
Yeah, yeah, it has got a
The
funny
part
name.
of
Yeah, it's the village where I have, I grew up. It is called Moscow. It's a very small village near to a river. And the good thing about that village is that it's little isolated from the mainland. So not much developments have happened. So it's good that it's still there with all the natural beauty that it has.
Yeah, so we've talked about this Shaiman. One of our my aspirations at least is to visit Moscow with Saif. That's
Yeah,
on
yeah.
the
You should
list.
go there.
Yeah.
Yeah.
Is it in Calicut district?
No, no, this is in Malappuram district.
Oh, I didn't know.
Yeah.
Sorry.
You're from Malappuram district, no?
Yeah.
Actually, you must be knowing Valanjeri, no? It's near to
Yeah.
Tirur.
Right.
Yeah, so this is 6 to 7 kilometers away from Valanjeri,
Okay. Towards the Pattam side.
towards Patambi side.
Yeah.
Yeah.
Okay. Yeah. Okay. Right.
Wonderful. So thank you for sharing that, Saif, because it also took me back to so many of these conversations from that period where there was so much of involvement of people from communities in shaping palliative care, right, and making it accessible in some of the most remote areas of Kerala. So
Yeah.
I think this is something which remains so fascinating for me over the years, especially when we're looking at now palliative care across the country and how to take it to different geographies. But before we go into palliative care, I really wanted to hear about what you're doing now with the bereavement
Yeah.
program, because this is a new development, and it would be wonderful to hear what you are working on.
Yeah. So for some of the comments that you shared, like community taking it up, I think that what Kerala has done is that from the starting itself, and thanks to the people who started the program, like Dr. Rajagopal, Dr. Suresh, and all, so they were convinced that palliative care is not a medical problem with a social issue attached to it, but it's a social issue with a medical component attached to it. And to address the social issues, when you talk about social issues, I'm talking about the psychological issues, the social issues, the spiritual crisis. So for this, the best people who can support this are neighbors, friends, or people who are already supporting them. So Kerala, like many other regions, it's like it's a very close-knit community. So when people are in crisis, they support each other. But when it comes to palliative care, they are doing their best. But sometimes what happens is that they don't know what to do because they don't have that training or the skill that is needed in that particular scenario. And also, the thing is that there is not much awareness in the society that this is a social issue, and people can do a lot of things when it comes to palliative care. So now what we have done is that I'm sure that you know about the neighborhood network in palliative care movement and all, but IPM has gone a step ahead. Now, what we believe is that palliative care is an essential life skill, like caring for someone who is bedridden is an essential life skill. So this is a life skill acquisition program rather than a volunteer training program now. Because there are two things that is really important here. One thing is that 90% of the people in any community will need palliative care at any point of time. So that means this is an essential skill that you will have to learn, and you will have to apply once in your life, either in your own home or in your neighborhood or in any of your close circle. So you will have to use that skill. So we are approaching it as a skill building program now. And when someone is dying or in the last phase of their life, most of the time they spend is with their family. So 95% of the time is with their family, because hospitals or the medical team, they have very less things to do. Like there are things that they have to do, but it's very less, because physical is only one component of the broader issues that they face. So what we are saying is that you equip the family members, you equip the immediate neighbors, family members, so, and also friends and whoever is there in the close circle of the patient, so that they can provide a better informed care to the patient. They are not replacing the role of doctors or nurses, but they are leading the psychosocial interventions as well as supporting the doctors and nurses in doing their work. So that's one side of that. And coming to bereavement, this is something that we have taken up very recently, thanks to the COVID crisis, because that was the thing that ignited the the program, or the need for the bereavement companionship program in Kerala. Actually, we were having a very wrong notion that bereavement support and things like that happens automatically in a very close-knit community. And more than that, we were thinking that palliative care is almost spread all over Kerala. And if you look at the representation of palliative care in that graph, which you have seen, you know that there is palliative care, dying, and then bereavement. So we haven't taken much care of that part, the bereavement. We haven't paid much attention there. Because of this wrong notion that if you are in a close-knit community, supporting people during their time of loss and grief is something that happens very automatically. Because we see that on ground, like if death happens, say for example, in my neighborhood, if someone dies, a lot of people, thousands of people will be visiting that house, and they will be, taking care of the family. They'll be cooking food for the family as well as the people who come there. Child care, a lot of things will be taken care of. And we thought that this is bereavement support, so you don't have to do much there. But when COVID came, in IPM, in Institute of Palliative Medicine, we had set up an helpline. So this helpline was for people who were in regular consultation with doctors, like not only for palliative care, like there are people who have serious health issues and they have been consulting doctors regularly, but because of their lockdown and things like that, they were not able to see or go to their doctors. So we developed a pool of doctors. There were around 100 of them from different specialities. And then our volunteers, they set up an helpline here. So the doctors, and there was a brochure which was published, and the people who wanted support of a doctor, they used to call the helpline. And these volunteers will connect this patient with the particular doctor from the particular specialty. And the doctor will give a medical advice to the patients. And whenever there is medicines needed, they will text the medicine to us via SMS. And then the delivery will be made at their home. The good thing about this program is that the delivery will be made by police, because the partnership was with Kerala Police. So wherever they are, in whichever district they are, the delivery will be made at their doorstep by the police department. So that was going on well. And then came the second wave. So during the second wave, what we witnessed is that a lot of calls were panic calls, because like any other region, during the second wave, what happened was there was a lot of deaths. So in COVID death, that the patient will be taken to the hospital, and that's it. You'll not be able to see that person again. You'll not be able to do the rituals. You'll not be able to say goodbye to that person in whatever way you usually do it in your culture or according to your belief and all. So people were, panicking. So they were calling us. And then we were thinking, like, what's happening here? We thought that bereavement and all these kind of thing support is automatically happening in the society. So it, it was like a food for thought for us. We thought like we should explore this more. And then we had a focus group discussion with people who have lost their loved ones during COVID and even before that, even before the pandemic. And then we realized that we were absolutely wrong, because the people who were in the focus group discussion, they said that, yeah, there is support for people when death happens in their family, but it's all very peripheral, like cooking food or childcare. All these are very, or supporting rituals and things like that. These are very important things, but very peripheral. But nobody asked these people how they were feeling, what's going there in their mind. They were not, able to sit with them and explore their emotions and thoughts, and at least being there to just to listen to them. That was not happening. And on top of that, some of the people who visits them and come, I mean, say something to comfort them, actually it was worsening the situation. It was hurting them more. So
Yeah.
people didn't have that knowledge how to support people during grief and bereavement. So then we got in touch with Kari Noonan from Death Literacy Institute, who have been in touch with us for a long time for various other projects. And then we developed this program. So basically, the idea is that this is when like palliative care, this is also a skill, because we say that 90% of the people will need palliative care, but if you take 100 people, all of them will die, and that means they will all leave their loved ones with a lot of emotional issues and other things, and which is not supported in a very scientific manner in our community. So this program was developed, and our idea is that once we are able to reach to a lot of people in the community, if there are 50 people visiting a house where death has happened, at least one person should be skilled enough to provide an informed companionship to someone bereaved. So that is the new addition that has come up now.
Thank you, Saif. It's always intriguing how palliative care in Kerala has been able to kind of respond continuously to these emerging insights, right? Because sometimes we see that organizations do great work, but then they stay with what they're great with doing. And in this case, we can see that there's a continuous response to perceived needs of the community. I was just curious that, so you said that you're working with the Death Literacy Institute in Australia, and there's some kind of, understanding of bereavement support. Is there something that you find is culturally specific to the way people are talking about bereavement in Kerala or in, say, Kozhikode and around?
Yeah.
There's some
So
cultural
it's like,
specificity. Yeah.
yeah. And of course, like when you talk about bereavement, things like that, it has got a lot of cultural undertones, and you'll not be able to replicate a model that you have developed exactly like that in some other context. So contextualizing the model is very important. But what we do in the program is that we have kept it flexible. Like there are 2-3 elements to this program. When we got to a workshop mode for developing the program, we kept this reality in mind. Like, of course, Death Literacy Institute has been doing a lot of work in the area of death literacy, and they have certain knowledge in that area. And what we have is that, how to interact with people, how to support people when they are emotionally down and when they are in crisis. So, bringing both this knowledge together, we developed a program. So basically, there are 2-3 components to it. One is like understanding yourself. Like if you need to support someone, you should have a good understanding about your own emotions, your own personality, and things like that. So one is that. Second one, the most important focus is how do you communicate with this person? How do you explore the emotions? How do you explore the thoughts that is going inside the mind of that person? And then how do you validate it? How do you sit with them? And how do you support them? Instead of providing, some unsolicited advice or trying to fix the grief of that person, how can you be a better presence in that journey of grief? So that I think is universal, quite universal, because these are the skills that anybody would need. But when you come to rituals and things like that, there it is very different. So we don't say that you have to follow a certain model. There are certain models that we discuss in the session, but we don't say that this is the model that you have to follow. Contextualize it according to your needs. But what we have seen is that from our practical experience, we have done this workshop for people from Philippines, people from Thailand, people from Bangladesh, and then this is a monthly workshop that's happening in IPM, in-person workshop, detailed discussions and skill building happening here every month. So, but we have seen that it's working everywhere, because it's not about how you're telling how you should be doing it, but we are giving some models and also how to communicate with a person. So this, from whatever response that we have got from this participant, we believe that this is working for them.
And currently it's only in person. Do you have them online as well?
We do occasional online sessions, because like when we did for Philippines, it was online. And for some people, it was hybrid. And we did online for Thailand, Bangladesh and all. Online, it's effective, but what we have seen is that it's more effective when it is in person, when you sit together, discuss and all. So that's why we are doing it in a in-person mode in IPM every month, and we've got a huge waiting list. That's the thing about it. Like, people come, and one thing that we have noticed is that most of the people who come there are people with unprocessed grief. So it's an platform them to openly talk about their grief. So like, people at the end of the day, I've heard these comments more than one time, like people saying that we had a good cry, but it was good. So that means even they had that grief which was not acknowledged or processed.
So Saif, I have a question here. So, who are the
Yeah.
people getting access to it? Like, in terms of providers as well as the patient. So, how? I mean, do they come and register at your institute, or do you go and find it? So, what is the process of it?
Yeah, this is open to all. So IPM has its own mechanism of publicizing these workshops, which we have developed. So like, we have good connection with the media persons here. So they sometimes write a story about it, and we have the social media page and all. And then we always put a number out. So people call and register here. We don't, we have not limited to this to any people from any particular background. This is open to all. So doctors, nurses, laypersons, housewives, volunteers, the people who have nothing to do with palliative care, they all come for this. And then we do the workshop. And then what we have, so by providing bereavement support, one thing that we make sure in the starting is that there are certain things that they have to keep in mind. One thing is that after the workshop, they will not be able to put up a board saying that Mr. Their name and a bereavement counselor, nothing like that. You'll not become a professional counselor, bereavement counselor after the course. This is a bereavement companionship program. And that what we say is that you will only use this skill in your close circles, either in your workplace, in school, college, in your neighborhood, among your family members, only in your close circles, because this is something as an act, like it's on the relationship that you build, that you have already built with the persons in your close circle. And then one or another element is that, so what we have, there are certain studies which they have done in Australia and all. UK, I think, has also done this. What we have seen is that, see, most of the people, they'll be able to process their grief by by themselves, like with the support of their close family members and all. Around 30% of the people, they will need some additional support. So that's where the companions come. And for around 10% of the people, they will need some extra support, a professional help. So the companions are taught how to identify complex grief, but not to intervene. So they identify complex grief, pathological grief, and they help them to seek professional support. So companionship plus helping people to seek professional support. That's the nutshell of the program.
Okay. Again, a follow-up question here. So, I mean, maybe you have noticed the kind of people who are registering now. So, have you seen any trend in number of people coming from the rural areas? Because for them, the awareness of this program will not be reached there yet. Yeah.
Yeah. It's in a very early stage now. So now this is in IPM, and IPM is in an urban setting in Calicut city, north of Kerala. So now most of the people that we get are from urban area, only because of the geographical proximity. People come from this city side. But we have people who come from other areas as well, from rural areas, from other districts. And since we have the accommodation facility here, they stay here and do the workshop and go back. And then what we have realized is that these people, when they go back, they are, kind of advocates for the program. They talk about in their platform, in their setting. And now we are getting calls from all over Kerala to go and do this workshop there. But I don't think that will be a sustainable model. So now what we are thinking is, like in the case of palliative care, develop trainers and also run a campaign around this, saying that integrate this into your program. But I think the demand is now little restricted to urban area because people are not aware about this. Slowly it's getting publicized among other communities as well.
Okay.
That sounds pretty incredible, because also I was also thinking when Saif was talking about you tell them not to be counselors, because I was just suddenly reminded about the whole Instagram influencers, how everybody is now a counselor, right? So you have this. So I'm glad you kind of highlighted that and said these are not counselors, but they are companions. And I think that's an important distinction, maybe.
Absolutely.
Yeah. So if you can tell us a little more about, this whole, you say you distinguish between life acquisition skill. So, that you say this is a life skill that you're acquiring, and not just like any other sort of professional skill. Can you tell the listener a little more about that? Like, why do you call it a life skill?
I think that's a pretty important question. If you look at palliative care in Kerala, I'm pretty sure that you have already done a very in-depth study about this. So one thing, when you talk about Kerala model, the globally renowned Kerala model, it's mostly around NNPC. There was a shift. First, when they started the program, it was a pain clinic, mostly looking into the physical issues of the patient. And soon they realized that it's much broader than that. So community involvement started. But when community involvement started, the focus was building volunteers. Like you are running a program, and then you need volunteers. You know that there are a lot of emotional and social issues to be addressed when the patient registers for care. So you see the need for volunteers. So you run a lot of campaigns to attract volunteers to your program. So they come, and then you arrange a training program for them. You arrange food for them. You arrange a lot of things for them. They come, learn, and some of them will volunteer for your program. And whenever there is a volunteer dropout, or when the trained volunteers, if some of them move away, they again run the program. So now the approach, the life skill approach, is nothing but we don't ask them to volunteer. If you look at IPM, we have already trained around 6,000 people now, and which is ongoing. Every month there is a one or two workshops. What we tell people is that, see, you will need this skill for your own family member, before they die. Learn this, better learn this. If somebody is dying, if somebody is in that last phase, you will not be able to set aside time and learn this and provide care to that person. So earlier the better. You learn the skill and then go back. And if at all there is a need in your own home or neighborhood, use this skill. And if you feel like upskilling or, I mean, if you want to learn more about this, you're always welcome to IPM, and we will provide you with the training and things. But at the end of the training, we will say that and there is an opportunity for volunteering. If you want to spend some time volunteering, you're welcome. But if you look at the whole 5,000 or 6,000 people we have trained, very few come for us to volunteer, and that's how we want to keep it. Like, we don't want them to come and volunteer. We want them to use their skill in their close circle. And the thing is that they have to pay. It's not a free training anymore. It's not a huge money. It's a break-even kind of thing. Like, if you look at IPM, it's a manual based. There's a particular manual which we have developed. It's a manual based 3-day intense training workshop, and they have to pay 500 rupees. But this covers food, manual, everything. So it's not much. But only thing is that they value it more. So if you say, for example, you want to learn the skill of driving, you go to a driving school, you pay money, and you learn the skill and you use it. So taking care of someone who is bedridden, who is dying, is a skill. So pay for it, learn, go back, use it. So that's the same approach we take. And if somebody is not able to pay, or if there are student volunteers who wanted to attend, we waive the fee. But we have kept it like that because we want to make this an approach. Like, we want people to feel that this is a skill that I need to pay and learn.
Great. Thank you for that clarification. My follow-up question is that you've been training people in different parts of the country as well. So now we have a sense of how this is vibrant in Kerala. But anything you want to share about some of your insights, how things have been maybe changing in the rest of India, some initiatives that are interesting along these lines? Anything? Share.
Yeah. I think that it's about the message and the people. Like, there used to be a sense among, or a feeling among people, that this is something that will work only in Kerala, because Kerala, I mean, there is something different about that place. So that's why all these things are happening there. But again, I think that it's just not about the geography, because death and dying is universal, suffering is universal, and willingness of people to help each other during time of crisis or vulnerabilities, it's there, it's universal. So then I mean, it's about what you talk about it. Do you, I mean, project this as a charity work, or a work that you can come and volunteer? I think that may not be a good model for a lot of places. But what we are essentially, if the message is that this is something that you will have to use in your life. See, people learn driving everywhere. People learn swimming everywhere. So like that, if people realize that this is an essential skill that we have to learn, then I'm sure that people will do it, because we have experimented this in Pondicherry, in Delhi, in few other places. So we have seen that once the message is clear, and if your intention is clear, that will kick off. People will come and take it. But most of the time, my feeling is that the people who start or run palliative care, even they are not aware about this. Like, for them, they are doing a good thing. They're running a program, and they want people to come and join them to volunteer. That approach, I think, may not be a good one for any community. So I think that this change of realization should happen from people who are running it, not from the society, because somebody has to drive this change.
So are you getting the same kind of support from the government like you received for the palliative care, for this bereavement support?
No, if you look at palliative care, so that's a good question, because even our approach for government collaboration was also a bit different. So now I'm in IPM. IPM is an organization which is now a World Health Organization collaborating center. It has got its own inpatient, outpatient home care programs. It run training sessions. So around we will have to spend around 2 crore rupees every year, because all the services here are free of cost, and we don't take any money from the government. So there were proposals. Even the government were asking us sometimes to put up a proposal, get money, do it. But what we said was that, no, we don't want to take money from government and use it on this institute. But what we want government to do is that integrate this service into the government programs, because this is the responsibility of government as well, not just community-based organizations. See, all other health-related issues, government is doing it. Government is running TB clinics. Government is running primary health centers. So if you are looking at health and well-being of the people, palliative care is an important element. You cannot leave it to certain NGOs or organizations. Take it up. You may not be having the knowledge to run it. What we have is the knowledge and the experience. We are able to support you. So that's how, when you read out the bio of mine, you must have seen that I was the first palliative care project manager for the government palliative care program. So the nature of that program is like this. Like when now it is NHM, National Health Mission. Earlier it was National Rural Health Mission. So when National Rural Health Mission was introduced in Kerala, there was a component to it, like innovative components was also something there. There were mandatory things that they have to do according to the government guidelines, but there was a provision for taking up innovative projects. So when a discussion was, because that's also the time when government of Kerala, published the policy. So during that time, when NRHM came, there was a discussion around what could be the approach towards the innovative program. So one thing that we suggested, like people like Dr. Suresh and all, they suggested was that try to integrate palliative care into the government system. They said that we'll experiment with the help of NRHM funds. So that's what they did. And there also the approach was quite different. In Kerala, somehow palliative care was not placed within the health system. Palliative care was placed within the local self-government, because I think that was a very important approach which was taken. And now the people who took it, I was speaking to them, and what they said was, it was not a planned move. It somehow happened like that because LSGD has the funds. So with the support of NRHM, there were few pilot projects which was implemented. So the project was like this: the local self-government plus NRHM funds will be pooled, and then there will be a basic home care program that will operate from the primary health center, led by a palliative care nurse. Sorry. So this is the model which was developed, and later local self-government, they decided that they will make palliative care a mandatory project. So every year, the local self-government, the basic local self-government units, the panchayats, municipalities, they will have to propose projects every year to the government. So there will be a government sanction for that. So in their plan fund, if they have not set aside any money for palliative care, the other projects will not get sanctioned. So that's a mandatory project now. So what they do is that with this money, they are posting a palliative care nurse. They are providing medicine and basic medical equipments for palliative care, like catheter and other things, and a vehicle for the primary health center. So every day, there is a basic palliative care home care which is being operated from the primary health center with the money from the local self-government department. So if you look at this model, we could have easily asked the government to set aside money for a palliative care program which is already being operational. That would have been easy for us and for them also, because they don't have to put into a lot of efforts there. But we said that that's not the way. Like, integrate this into the government system. So if you look at Kerala now, each and every local self-government has a basic palliative care unit now. Plus other facilities in the secondary and tertiary unit. So it's not that government supporting the NGOs or the community-based organizations. It's government doing their role in the government system in primary health centers and other hospital setups. So then that doesn't mean that the CBOs or NGOs will become irrelevant. So there was this, the people were little frightened. They thought that if government take this up, what about all the good works that we have done? So actually, this is very complementary. Like if government is able to take care of the basic palliative care needs, the community-based organizations can build on it. Like they can do many other things. Say for example, in my village again, if the patient is in need of a catheter change, they don't have to go to the NGO or the community-based organization. The panchayat will come and do that. But if there is a tracheostomy care or a colostomy care, especially palliative care, the facility is only with us. And again, if the patient needs emotional support or social support, the panchayat or the PHC will not be able to do that. But that the local community will take care based on the training that they get. So this is because there is a huge need. And if there are as many players in the field, it is very good. Like if you look at Kerala now, there are political parties running their own palliative care. There are religious groups running their own palliative care. There are community-based organizations. There are panchayats and primary health centers doing their role. So I think that everybody has a role. It is not that if some other player come to your place, you'll have to close your program. Nothing like that, because there is a huge need.
Yeah, no, thank you for that. That was a great system level view of palliative care provision came from you. Also, I remember that the time that I started my research in 2009, that was a time when that policy had just come out. And so in different places, we would get these mixed responses that, some people would welcome it and some people would say maybe nothing's going to happen, those kind of things. So there were many kinds of responses. So it's fascinating to see the kind of collaborations that have come out of this, the possibilities, where the community's strength is there and the places where you need the state and, there's no other substitute for the state. But I realize we've been, we've taken a lot of your time. So I feel like I've just a couple of questions before we, let you go, which is that, you've been with palliative care for so long, right? And this is a very morbid question in that sense, right? That people say that you're talking about bereavement, you're talking about death and dying on a, sort of daily basis. So can you tell us, what does it mean to you? Like, why have you said you're passionate about palliative care when we started out, right? This is a passion for me. Can you tell us what is it that has sustained you for so many years to be committed to this particular cause?
Yeah, I think there is no easy answer for that. Like, every morning you get up, what you think is about the programs that you're going to do that day, the people that you're going to meet that day, or the workshops that you're going to. So I enjoy this. Basically, I'm very grateful to palliative. It's not that people are being benefited out of my passion or dedication. It's vice versa. Like, I'm so happy about this. So I'm sure that people will be happy about a lot of unique things. For me, I don't know. I'm simply happy about being with in the space of palliative care. And what I do is that I run a lot of training programs, workshops, and all, and that makes me happy. So I do this. I'm not saying that I'm doing a big thing. Actually, I'm the biggest beneficiary, because you see, at the end of that day, what you need is that you should feel that you have done something purposeful, that you're happy about it. See, if I've been a pharmacist and running the family business that my father had set up, I would have made a lot of money, but I might have not stayed happy. But now I think that I'm not making huge money, but the thing is that I'm doing what I like. So even during my college days and all, this is what I used to do: train, speak, connect with people, and do a lot of things together in a team. And this is an area, a perfect platform for that. So, and also, there is a lot of personal learning that you gain, because I think that you benefit out of the interactions with people. See, the place I'm joining for this interaction is from IPM, and IPM is a place where at least one death will happen in it. So at least one death, and you are spending time with them, the person who is going to die the next day, and also with their family members. And the wisdom that you get from interacting with them, you'll not get it from anywhere. You can read books, you can watch movies, you can talk to people, but someone who has a lived experience of a full life and who is going to say goodbye to this world, interacting to them, I think that's the biggest learning and opportunity for you that you can ever ask for. So for personally, it's very beneficial. The most important thing, as I said, is that I'm very happy here. So I thought that I'll continue with it.
Thank you so much. That was such a beautiful answer to this question, the very ordinary, mundane question. But clearly, I've also witnessed it personally. Of course,
And this is the platform where I meet people like Devi, Shaima, and all.
like
Yeah.
so grateful for the work you do and for everything that's going on at IPM. Shaima, do you have any questions or anything to add?
No, thank you so much, Saif, for joining us and contribute your thoughts to the supper team.
Yeah. No, this has been lovely. I feel like we might come back to Saif again for another conversation, because there's so many things that's going on at IPM. There's always something new. So I feel like hopefully we have another chance for another
Maybe
conversation.
we should do an in-person supper in
Yes.
IPM.
I would love that.
Yeah.
I would
Sure.
love that.
One
Yes.
thing that we have now started is something called Death Cafe. It's not a new concept, but
Yes.
something like that. Like you casually
Yes.
sit and talk about a lot of things. Yeah.
We'll
So that'll
see.
be great, because
Yeah.
all the other suburb members who are not there today are also big fans of Kerala anyway. So they will also be happy to take that opportunity to come down to Kozhikode.
Yeah.
Always
Absolutely.
waiting for.
We'll go to the Moscow village.
Yeah, yeah.
Yes, go to
Maybe
Moscow.
we'll hold a Death Cafe by the bank of the river.
Yeah, it will be beautiful.
That would be something great. Thank you
Yeah.
so much, Saif, for joining us.